10 seconds, 5 seconds. All the existing national and state level publicly funded insurance schemes in India have identified target populations that are eligible for the particular schemes. However, several schemes have in fact resulted in mistargeting or missing the target altogether. There is a fundamental problem with using the below poverty line lists as the criteria for inclusion and exclusion are faulty. For instance, widows or women headed households tend to get excluded. There is also no realistic understanding of urban poverty for the purpose of the lists. These lists are also not updated regularly, excluding those who have been recently impoverished. Thus, these schemes do not take into account the fact that there are existing social exclusionary processes that exacerbate the situation for the vulnerable and marginalized, and therefore they are unable to gain any benefit from these. Migrants, tribals, and deserted or widowed women were found less likely to be covered by insurance schemes. The inability of the schemes to provide coverage to the eligible population is highlighted by the fact that enrollment rates are as low as 2.45% as in the case of the Rajiv Gandhi Jeevandayi Arogya Yojana and less than 5% in several states under the Rashtriya Swasthya Bima Yojana. The private sector, being largely urban and profit driven, has led to inequitable empanelment of private hospitals and promotes more profitable and quick exit procedures under the scheme. Thus, the schemes fail to make available several specialties despite including the private sector. The Center for Enquiry into Health and Allied Themes published its report titled Government Funded Health Insurance Scheme in Maharashtra. Rajiv Gandhi Jeevandayi Arogya Yojana, though a private hospital under study, is this report had 17 of the RGAY recognized specialties available. It actually largely promoted only 3 to 4 of them. In general, under the RGJAY, specialties such as medical oncology are unavailable through the private sector in 12 districts. Intervention oncology is unavailable through the private sector in 17 districts and radiation oncology in 16 districts. Even specialties such as nephrology and cardiothoracic surgery were unavailable through the private sector in almost one-third of the districts of Maharashtra. The urban-centric nature of the private sector means that gaps in the public health sector have not been filled through partnerships with the private sector. Thus, Nandurbar, with more than 65% of its population belonging to scheduled tribes, has only one empaneled hospital, which is a public hospital, and no private empaneled hospital. This leads to significant inter-district travel, adding to costs. In the case of Nandurbar and Bid, about 90% pre-authorization were raised in a different district. At the National Conference on Health Insurance and Universal Health Care in India, organized by CEHAT and Tata Institute of Social Sciences in Mumbai in October 2017, evidence across the multiple studies presented also clearly shows that there has been no significant impact on the out-of-pocket expenditures incurred by the poor, and none of the schemes were cashless or envisaged. The reasons were several. Patients and their families continued having to pay for diagnostics and medicines, and the practice of reimbursement of costs is common. The situation for the poor can get aggravated if the claims are rejected or there are delays in settling claims or reimbursements. The continued inter-district travel mentioned earlier also adds to cost of health care. The Mega Health Insurance Scheme, based on the RSB, in fact follows a reimbursement model. Here too, the OOPE was high, reimbursements were delayed, no credit was available to registered patients, and expensive medicines needed to be bought from outside the hospitals, adding to the tedious nature of the scheme. Besides the cost, high OOPE is also a consequence of the absence of the continuum of care approach, as the maximum expenditure is incurred by the patient prior to reaching tertiary care services and at level of the outpatient department. It is also bizarre to think that the government is willing to pay much more for the same services that would be cheaper were they made available through the public sector. It is also argued that strengthening the public healthcare facilities will lead to an increase in their utilization. This will lead to a decrease in OOPE and reduce the dependence on the private sector. State schemes wherein there was incentive to recruit patients under the scheme led to the public and private sectors competing for the incentives at the cost of the health of the patient. Patient care was found to be delayed until the required procedure could be covered under such schemes. This creates serious barriers in access to health care, awaiting health issues to be escalated to tertiary levels in order to have them covered under the scheme for the purpose of increased incentives in unethical. The government has been a key facilitator in the growth of the private sector in the country.